that visible properly? Perfect.
All right, so good afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on STI HIV testing in Ontario, the GetaKit study. My name is Fiona Guerra, and I'm a Senior Program Specialist in STIs and BBIs here at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin, there are just a few housekeeping items. So first, the chat pod has been disabled in order to limit distractions during the presentation. So please use the Q&A pod if you have any questions during the session. And a discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. And I would like to state that as moderator of this session, I do not have any potential conflicts of interest to declare. So it's now my pleasure to introduce our speakers for today's presentation, Patrick O'Byrne and Alexandra Musten. Patrick is a full professor of nursing at the University of Ottawa and a licensed nurse practitioner. His research and clinical work focus on the prevention, diagnosis, and management of sexually transmitted infections, including HIV. Dr. O'Byrne is the principal investigator for the GetaKit study. Alexandra Musten is the senior lead of testing and clinical initiatives at the Ontario HIV Treatment Network, where she coordinated the implementation of pharmacist-delivered HIV point-of-care testing in Ontario. Ms. Musten is the co-lead for the GetaKit project. So without further ado, I will hand it over to our presenters.
Thanks, Fiona. Thanks for having us. Thank everyone for coming. I see the number of participants increasing continuously, so that's good. We're very excited about GetaKit. We think it's a very interesting project. Happy to share it with people. Glad people are interested as well. And so I think without any further delays, we'll jump right into it. The presentation, at any point, if you have questions, please put them into the chat. Alex and I will be sharing what we're doing. Fiona will be moderating as well, and we'll make sure we leave time at the end to answer them. And if we can answer any that pop up throughout, we'll answer those as well to the best of our abilities. So first one, this is the disclaimer from Public Health Ontario. Document presentation has been prepared by me and Alex. It's our material. PHO will be offering it according to their standard website terms of use. They're not the owner of the content, nor are they responsible for it. No liability. This is our material that we are presenting. For our disclosures, funding for GetaKit as a research study was obtained from the Ontario HIV Treatment Network, the OHTN. Neither Alex nor I have any conflicts of interest to declare. I would like to thank the OHTM for my research chair in public health and HIV prevention, and then acknowledgements for everyone who's helped us from setting up to doing social media to implementing to following up with people to mailing out kits, absolutely everything. Just to thank a bunch of people who've helped us, who've actually helped us program the website, but we have our sort of list of acknowledgements there. So the background, the context to this, epidemiology. We are all quite familiar with all of this, but there's a few key points. These are the actual updated infectious disease trends in Ontario from Public Health Ontario. You can see basically bacterial sexually transmitted infections are up across the board. Gonorrhea, chlamydia, syphilis, we are well familiar with. HIV is remaining relatively stable. The key point to this, and this is an analysis did a couple of years ago with Dara Friedman, who's an epidemiologist for Ottawa Public Health, took a look at. So we see that gonorrhea, chlamydia numbers were up. They have been trending up. We had a massive sort of spike increase around 2017. You can see the red bars of sort of a 20-year layout. We wanted to say, was there anything that changed? Because we know these are up, but we also know gonorrhea, chlamydia are not systemic, right? They can be in specific sites, whether this is urogenital, oral, or rectal infections. And so we really wanted to see, was there anything that we were seeing? You can see in the top right in that bar, there's a blue section, and then there's this mustard section that comes in. And we wanted to see the impact from our testing that we were doing in the sexual health clinic in Ottawa. And this is actually just, that number there is for all of Ottawa, to say what's the impact of when we worked with Hassle-Free and Public Health Ontario lab to validate the extragenital testing as NAT. And what you see is the proportion of extragenital testing across the city of Ottawa during the time periods that are identified exclusively in the extragenital areas compared to genital in any other location. And we see this massive increase that's corresponding with that increase that we're seeing at the time. So part of what we have is just an artifact of improved testing technologies that's inflating what we're seeing, but it also is telling us that a large number, a huge burden of these infections are actually located outside of the genital area. By numbers, we took specifically those which are in the sexual health clinic. So that's the clinic operated by Ottawa Public Health, and said, if somebody were to have exclusively an extragenital infection, so this would be one that wouldn't be detected by a urine test, right? What proportion did we have when we were doing culture? What proportion did this constitute once we actually switched to the nucleic acid amplification testing, so the NATs? And you can see in the table on the left for gonorrhea, you have this 31%. I'll circle it here, right there, the 31%. So around 1 in 3 infections were exclusively extragenital. So it was oral, it was rectal, and the urine test in these cases actually came back negative. Once we switched to NAT, this number actually increased to almost 70%, as you can see there. And putting this into a simpler way of saying it is, once we were doing the NATs, we know that for every 3 infections we would identify for urine testing, there'd be 7 that we would miss that would be exclusively extragenital. For chlamydia, the increase was from around 40% up to 2/3. So it still increased dramatically. So this is telling us that yes, the numbers are up in part probably due to improved technologies, but we're doing much better case finding, and missing the extragenital testing means that we actually would be not identifying, not diagnosing, not being able to treat, not being able to do the important sort of contact and case management that we need to in all of these different instances. We also know for HIV, despite basically all of our best efforts of peer-based testing, of clinic-based testing, of outreach settings, of previous pharmacy-based initiatives, we have here from the OHSI data that still around 14% of people who are living with HIV in Ontario remain undiagnosed. The numbers are relatively stable, and this is despite us doing a variety of sort of excellent outreach, implementation, point of care, serology, pharmacy initiatives, right? We have the context. So putting this all together, the context of where we came from was bacterial STI rates are up. We know that a huge burden of these infections are extragenital. HIV rates are remaining stable, and we still have around 14% of people remaining undiagnosed. So that's the context within which we're operating. Piling onto that then came the COVID-19 pandemic and all of the restrictions for in-person care, knowing it's exceptionally difficult to get access to STI clinics during the pandemic, to do in-person testing, to have blood work done, to have oral rectal swabs done, to have cervical swabs done. This just sort of compounded to create the entire context within which GetaKit was born out. And so I'll turn this over to Alex to talk about that part.
Thank you. Can you get to the next slide?
Yes.
Thank you. Okay, so the GetaKit project launched in Ottawa, July 20th of 2020, and is at its core a study to evaluate the mail-out delivery of free HIV self-test kits. As Patrick mentioned, COVID was a big factor in us launching around that time, and it was before the approval of the test device. It was actually under review by Health Canada at the time. But we applied and secured special access to be able to launch ahead of approval. And we felt that this was really important because there was a tremendous decrease in availability of HIV testing in Ontario, just because of the redirection of attention to COVID. As part of the evaluation, we really wanted to know how many people were using GetaKit, who was using GetaKit. So more specifically, were we able to reach Ontario's HIV priority populations? What were the test results? And were the participants who were reporting positive results being successfully linked to confirmatory blood work and treatment? Next slide. So this is the landing page of the Ottawa GetaKit website. You can see the eligibility criteria is just right there at the top. So people are able to order a kit if they're 16 years and older or older, HIV negative or are unsure of their status, not currently enrolled in an HIV vaccine trial, and not diagnosed with a bleeding disorder. PrEP was originally an exclusion criteria, but that was dropped a few months ago. And there's a reminder for anyone who says that they're on PrEP that they should be seeking regular testing through their PrEP. Next slide. So this is a high-level overview of the basic flow of GetaKit. So essentially somebody arrives at the website, they determine their eligibility and they register. Registration is a broad term for providing us with their contact details, an address to be able to mail the kit to, and to answer some self-assessment questions around HIV risk. If the registration is incomplete, we leave it as incomplete. The participants are also supposed to be validating either their email or their mobile number via text. And this part was especially important in the beginning of the pilot because we wanted to make sure that we could get in touch with anyone who reported a positive result. So once all of that's been confirmed, the person can go ahead and order a test. If they've completed their registration but didn't go through with the order, there's a couple of reminders just to make sure that it's not an incomplete order. And if we don't hear back, then we just close the file. Once the test has been ordered and delivered, we encourage participants to report a result. There's a couple of options. So there's positive, negative, an invalid result, or participants can also say that they would prefer not to report. So it's not mandatory to say anything unless they want to order a new kit, but we do have that option for not letting us know whether it was positive and negative, just to encourage people to keep retesting if that's what's working for them. If we don't hear back from them, there's two instances of reminders as well, just to make sure that people are, we're checking in to make sure people are able to use the device, that everything's going okay. And we often get a little uptick in people reporting results after those reminders. We take a status neutral approach as well to the GetaKit program. So if somebody reports a negative result, the GetaKit team will follow up to talk about when to retest, any kind of prevention materials, and a reminder to retest at 3 months. When somebody reports a positive result, someone from GetaKit will get in touch with them as well to link them to confirmatory testing, provide them with more information around HIV and any other resources they may need at the time, including mental health or crisis linkage. Next slide. So this is the GetaKit box. This is a part of the GetaKit program that we're especially proud of. We really wanted to make sure that when we were mailing out the kit that we weren't just mailing it out as is. So this is around the size of it. I was trying to think of a good way to compare size. So this is my phone. So it's a little bit smaller than a phone, and you can tell that there's no distinguishing characteristics on the box that would indicate at any point that it's for HIV testing or for sexual health testing. In fact, a lot of the feedback we got in the beginning was that it looks like you're getting a phone because it says hello, hello on the side. So what it does is it folds out into a sort of placemat, and it sort of reads the same way that you would as a book. So some reassuring information and language in the beginning, some information around the contents of your kit, but then there's this workstation at the end. And we know that the testing device has a couple of components. So we really wanted to make it easy for people to organize it in order to use the test. And then some information around local linkage to care. So there's also a lot of opportunity in the box to be able to add other resources. You can see in the photo that there's condoms and lube that are included. There's the test kit itself. And then there's an 8.5 by 11 folded sheet around information about HIV. There's also other opportunity to add other resources as well. In fact, we're going to be adding Indigenous medicines to it at the request of one of our new Indigenous ASO partners. So we're really excited to be able to provide that. Next slide. So this is a table summarizing the characteristics of the participants from phase 1. So you can see that 71% of people self-reported being a member of a priority population. And this was the majority of whom were white gay men between the ages of 26 and 49. And this is to be expected as it's a group that represents a large proportion of HIV diagnoses, and they're also very familiar with HIV testing. Below, the table below also talks about or shows us the percentage of people reporting results. So it's about 57%. And of that, 77.6% reported a negative result. There was one reported positive result as well. And 20.6% of participants reported an invalid result, which is higher than what we wanted. And so we since have put together a couple of strategies to reduce that and have successfully reduced it by about half. Next slide. Thanks. So shortly after launching in Ottawa, we were approached to expand to 5 ASOs in Ontario. And this is a great opportunity, and we wanted to be very careful about it and build an expansion model that centralized a lot of the logistics around storage, quality control and assurance, and shipping to Ottawa. And then we would have the program be supported by regionally specific services. So when we approached the first 5 ASOs, we really took our time to understand what kind of services they were offering, any adaptations they had to make because of COVID. We knew a lot of people weren't working from the office, and their previous experience with HIV point of care testing. And I believe that this was a really good indicator of the types of training and resources that we would need to prepare for sites, especially in the case of navigating linkage to care. It didn't seem like that was a piece of testing that they had previously been involved in, and we wanted to make sure that everyone felt very comfortable when they were doing follow-up with participants. We also wanted to learn a little bit more about the types of barriers that clients were facing when accessing HIV testing previously. We learned a lot from these conversations. We developed resources, different templates for them to fill in. We also encouraged them to customize the information that they had for each region, so that linkage to care was sort of a warm handover. We hosted training sessions and developed a user guide for staff to refer to when they were doing follow-up. Next slide. And what this meant was we could rapidly scale up from the first 5 ASOs to 13 with a couple more in the waiting rooms that we're going to be launching in the next couple of months. And we were able to do this within 5 months, which I think is a huge achievement. Our shortest turnaround for implementation was 10 days. So now our GetaKit hub site looks like this. So any participant can go to getakit.ca and look to see which ASO in their region is offering GetaKit. And if they don't see their region there, they're encouraged to register through Ottawa and surrounding regions. And overall, what we really emphasized was that participants were self-testing, but not testing alone. And this was an approach that was just as relevant for our ASO partners. We really reassured them that we were never far away if they had any questions about follow-up or about processes. We were always available to provide additional training, especially if there's new staff coming on board. And we always want to hear about their suggestions that makes GetaKit more accessible. So we try to share as much as possible between the sites, knowing that there's a lot of similarities, and we're really trying to build a strong HIV testing network across the area.
I believe it's back to me. So phase 4. Now, if you're following the numbers intently, you're going to notice that I skipped 3, and that was on purpose. We'll come to that after. So phase 4 is taking what we've built through the GetaKit system and its automation and its actual risk assessment logic, which is basically an artificial intelligence that we've built into the system. And say if it can screen somebody in or out of HIV testing, do we have the ability to actually program it and actually have it do the interface correctly to match recommendations for all other recommended STI testing? And so the goal with this expansion was to move toward gonorrhea and chlamydia. And this would be for full testing, whether urine, self-vaginal, oral, rectal, syphilis, HIV, and Hep C serologies. And then the same questions we're proposing for this, and to say, like, what is the uptake? What are the outcomes? What are the linkages to care? How many people have different types of test results, positive, negative, indeterminate, canceled, and so forth. So that is our intent with this. So working through it, I'm going to take a couple of case examples, walk through it, and then actually show you how the system works with it. So case example 1 is a 24-year-old Black cis female who presents to a clinic for routine STI testing, reports no symptoms, no concerns. The last reported sexual contact was approximately 3 weeks ago with a new cis male partner. Reported sexual contact was oral sex given and received, vaginal sex, no condom use. She informs us that her last testing was around 2 years ago and has, in addition to that, one partner from 3 weeks ago, other partners, denies any previous STI diagnoses, and she has a Mirena in situ for approximately 3 years for contraception and has been subsequently amenorrheic for the last 2 years, so no menses. So the question is, right, if this is the type of person who presents, how do we take that and say, what are the services that are indicated? How do we make sure that GetaKit can actually offer it? So it starts with going into the guidelines. What are the recommended services? If this person would present to me in the STI clinic, absolutely no symptoms, routine screen, no prior infections, nothing of particular interest in the history, right? Relatively unremarkable other than looking for a routine asymptomatic STI screen. From this, gonorrhea, chlamydia, NAT testing, self-vaginal would be recommended, syphilis serology, HIV point of care, and or serology being recommended. Follow-up plans, we'd also want to make sure we repeat this testing outside the window periods, and it's important just based on her age to ensure she has previously had the non-valent HPV vaccination, so Gardasil 9, and an appropriate hepatitis B series for her age. These would likely have been done if this was somebody who went through the public school system in Ontario, but some people opted out, some people moved, other people arrived at different times, so it's important just to ensure that all of that is done. Where does this come from? Really comes from the Public Health Ontario guidelines, both for gonorrhea testing and just through their abstracts and their recommendation through their websites on the actual testing. The urine test is not the recommended test in this case, and so as we move forward to building the automation in the GetaKit system, it's to say, how are we going to differentiate between somebody who would be doing an internal swab and somebody who would be doing a urine test? And the rationale for that really comes from, right, the patient collected swab being here, the sensitivities are exceptionally high, and in fact, in many cases, outperform clinician performed sensitivities as well, right? So you have here as well for chlamydia, again, you have an exceptionally high performance. And again, in both cases, it is really our highest performing tests that we have. For oral and rectal swabs, you may say this could be something this fictitious patient did report performing oral sexual contact on male partners. They had mentioned high rates of extragenital gonorrhea, chlamydia being identified. Our study was looking more specifically across the city of Ottawa and then more specifically into men who have sex with men. And so from the guidelines, you can see from Public Health Ontario, the recommendation is for MSM sex workers and people who their contacts, and people who are known contacts of gonorrhea, chlamydia, with a little blurb below saying, at present, it is not that this is not an indication for women, but this would be a clinical decision to be made based on sort of the current positive evidence that we have about this. So it's not to say don't do it, but if we're automating a system to look at how do we offer it, this is not a situation where I could come up with a clinical indication because there is no actual clinical interaction, right? It is a self-report, and then it is the automation based on the guidelines of what's recommended. So it comes back to, in this point, when designing our automation, we had to make sure that if somebody presents with these factors, right, that we have this actual recommended test list. So it actually needs to differentiate as well between the recommendation for the self-vaginal and the urine test. As a second example, and then we'll get into the automation shortly after, is you have a 42-year-old white cis male who presents to the clinic again for routine testing, no symptoms, no concerns as well. Reported last sexual contact was about 5 days ago with a new cis male partner, also has trans female partners. Reported sexual contacts, practices, oral sex given received, anal sex top and bottom, no condoms. He was last tested around 7 months ago, new partners since. Past history includes rectal chlamydia approximately 18 months ago, and an early latent syphilis around 7 months ago. So diagnosed asymptomatic at the time. So what are our recommendations for testing for this person? So gonorrhea, chlamydia, nucleic acid amplification testing, and this should be in the pharynx, the rectum, and the urine. Again, knowing if you miss the extragenital testing, from our identification in the STI clinic in Ottawa, we would miss 70% of gonorrhea cases. We would miss 2/3 of all chlamydia cases if we were to just do the urogenital testing. Syphilis serology is exceptionally important. We are all very well familiar with the rapid and massive increases we have experienced over the last decade in infectious syphilis, so making sure that this is run as testing as well. HIV point of care and or serology, and then hepatitis C serology to be considered based on age, sort of the recommendation for baby boomer testing, right, to ensure we have that one lifetime test in. Other recommendations, PrEP, right? This is something the HIV pre-exposure prophylaxis should be offered, and then vaccinations, hepatitis A, hepatitis B, and the non-valent HPV vaccination. What is supporting this? Right. So first off, we have the United States Centers of Disease Control actually just recently, I believe it was July 24th, released their updated STI guidelines. And while some pieces for STI prevalence, right, won't necessarily translate to us locally, what they do have is some pretty good research evidence supporting, right, objective indicators of HIV acquisition. And in that top paragraph, lots of words, but the part that I've sort of gray highlighted, you can see that they say that for gay men who are diagnosed with a rectal bacterial STI, so gonorrhea, chlamydia, 1 in 15 of these men often become HIV positive within 1 year of that diagnosis. And for infectious syphilis, primary, secondary, the rates are around 1 in 18. So you have pretty clear recommendations of this. Man said he was diagnosed 18 months ago, right, with rectal chlamydia, 7 months ago with an infectious syphilis, although early latent, which is not what's listed here. But we have a risk factors, right, both of them coming in under 1 in 20, saying that we have a pretty high risk factor identification, right, to offer PrEP. And so this becomes key for us as clinicians, public health staff, other members of the community to advocate for and say, right, these are things that we need to be paying attention to. For the Gardasil 9 vaccination, you can see that typically we have the 26 and under recommendation, increased to 46 for women who are sexually active with risk factors. For MSM, there's actually no upper limit for this from the NACI guidelines, and I've highlighted it here, saying if there are risk factors, right, there is not a lot of evidence to support us giving the immunization, but it should be strongly considered, right, if there's actually risk due to the sort of harms and potential negative sequelae that can arise amongst MSM for HPV. So remembering PrEP and our non-valent HPV vaccination as well. PrEP, just wanted to show this. So PrepRN is a nurse-led clinic plus a referral service that operates through Ottawa Public Health, and everyone is very much familiar with case and contact follow-up, particularly since COVID. So what we did in 2018 through Ottawa Public Health is we actually said anyone who has a diagnosis of a rectal bacterial STI or is a case of infectious syphilis and HIV contact, we immediately started offering, like actively offering PrEP access to them. And what we have is this massive, almost 50% decrease in HIV incidence in the city of Ottawa that was maintained through 2020 and so far into 2021. The 2019 numbers are our best sort of comparators because the actual volume of testing didn't change. We know in 2020 and 2021, the rates of testing did go down. We know that's the case across the province and basically around the world. But in 2019, without any changes in the percentages of different populations who were testing, the sheer volume of testing that was occurring, we actually saw this massive decrease that has remained down. This is interesting because often when you see local STI trends, they fluctuate in direct relationship with the ones that are occurring at the provincial level. And what we have actually is the provincial level not really changing. They've stayed relatively flat and stable for HIV rates across the province with a 50% decrease in Ottawa. And in fact, in 2019, that slight dip that you're observing in the top left is accounted exclusively for by the decreases we observed in Ottawa that correspond temporally, at least, with when we actually implemented this. And this, I think, the true power to the PrEP service here is not necessarily the clinic in and of itself, but it's the involvement of Ottawa Public Health. And I mean, this is really a testament to the work they're doing on this to say, yes, we're going to implement PrEP referrals as a standard practice in cases where people are identified as having these objective risk indicators that the CDC just said your risk is, right, 1 in 15, 1 in 18 of becoming HIV positive within 12 months. So we really took this and moved it forward. So just as sort of some evidence. The next thing, just before we get into the actual website, is what does the Public Health Agency, the STI Guidelines, actually say in their primary care recommendations? It's this bullet 2, and it says you really have to take this understanding of local epi of STI plus risk factors. And this is always something that basically everyone's trying to do and saying primary care has to be doing more STI testing. I am a nurse practitioner, have done this work in primary care, locuming, walking clinics just for general practice. And so I completely empathize with primary care, who we have this expectation that they're going to know every epi trend about every infection and every disease for everything there is and how to do all testing. And it is the job, but it is also difficult. And so part of what we wanted to do with GetaKit was to say, well, we can actually automate this, right? It's easier for us to control the epi data, for us to actually have some control over the risk factors, and we can tailor and tweak this as the actual experts. So this is what we went into. The logic, so this is the article we published on how we actually built the automation and the algorithms. The logic behind it is relatively simple once we figured out what we were actually doing. The 2x2 matrix here is really you're at low risk or high risk for 2 factors on the X and Y axes. Along the X axis, so our horizontal axis, we have the risk of transmission. This is pretty simple. If we were to have somebody who had an infection and somebody who didn't have the infection, if they were to come into contact with one another, what's the chance of transmission? What sexual practices were engaged in? Can this sexual practice actually transmit that infection? Were there barriers, condoms, so forth used? Was chemoprophylaxis, PEP or PrEP involved at the time, right? To actually say what's the chance of transmission occurring? Along the y-axis, the vertical axis, the question though becomes, because most of the time we don't necessarily know if somebody was truly exposed. And so it comes into what's the probability of an individual being exposed. And the best proxy measure we have for that is going to be prevalence within specific groups. And for HIV, we call these priority populations, right? Which groups are most affected by HIV, which means which groups have the highest incidence and prevalence. And so we'll really look at those 2 factors. Now, figuring that out, you just have to plot the intercept, and cognitively we can do that, right? We can move people along the two axes in our minds and have a good idea. When we went to automate it, it became a bit interesting because the actual y-axis doesn't move in a necessarily linear fashion. It's an exponential curve. You end up having to actually multiply odds ratios. And so if we take COVID as a very simple example, if you were to live in a multi-generational home, right, we would say that's 1 point for a risk factor. If we add in as well that an individual is BIPOC, Black, Indigenous, person of color, knowing that we have such a higher burden currently for COVID, it's not going to be one risk factor plus one risk factor giving us 2. It's actually going to increase from 1 to 10, right? And then if we add in another risk factor, so the person right ends up with a symptom, or an individual they're exposed to has a symptom, it will go up to 100 points, right? So it moves through this basically logarithmic faction. We figured out the quadratic formula that maps it up, but that's really, we understand this intuitively once it's explained, but it took us a little bit of time to actually sort of map this out. Once we figured out this exponential curve and the actual arc to it, or the slope to it, basically everything started following in alignment with the guidelines, which is what we were hoping for the entire time. So this is how we started, and I'm going to stop sharing this, and I'm going to share now another document, which is here. And Alex, am I sharing the right thing? That's the Sheets document.
Yeah, I see it.
Excellent. So this is the actual sort of base on what we built in the background. So we have along the top all the tests. We have actual thresholds, numerical thresholds that people have to exceed. You have all the tests here, and you have this long list of no's. So if we take that first case, which was a woman who was cisgendered, who reported sex with men, who said she was Black, she was last tested more than 12 months ago. There was nothing reported of bisexual endemic for partners sharing injection drug equipment. We don't have that. She was 24 years old. She had a new partner. There was no report of injection drug use and no report of sex trade work. For risk practices, which is just on a different sheet, right? So this has a vagina. She reported oral sex given and received, and vaginal sex received. Now, when I go back to this page, right, we have a series of yeses, and this is how we built the actual logic. So you can see the HIV testing as serology and or point of care have been recommended. The vaginal self-test has been recommended, and the syphilis test has been recommended. And so it has basically followed exactly the PHO guidelines that we were referring through, and it has come up with the exact same list and sheet that we saw. If this is actually sensitive enough that if we change her from being Black to white, the HIV self-test disappears. And the logic behind this is African Caribbean Black populations, particularly women, have a higher prevalence or incidence of new HIV diagnoses. And so linking to more options for testing and care is exactly what we wanted. And the sheet is the logic and artificial intelligence we built is sufficiently or has sufficiently high resolution to actually show that. So as the second example, we had a man. Actually, I'm going to clear out the second page. So we have no reported risk factors or behaviors yet. So it was a man, cisgendered, sex with men, white, last tested, I think it was 60, yes, he last tested 7 months ago. Partners, we're not sure. He was 42, had new partners, and no injection drug use, no sex trade work that was reported. Had a penis, said oral sex given and received, anal sex given and received. And back to the results, we now have HIV, is serology and self-test. We have oral, rectal, and urine testing for gonorrhea, chlamydia, and syphilis testing. Right, all coming in as indications. No, the consideration of Hep C is there, not indicated in this case, as we don't have it, right? Anything really showing. So this was the back end, and this is how we started. Then we actually built it into the system, which is the next thing I will show. So Alex had showed, I'm going to check again, Alex, I'm now sharing the actual hub page.
Yep.
Perfect. So now we have, we have the pictures, right? This is the actual landing page that people come onto where they can pick all the different sites, right, that they want to go through. I will select Ottawa just to log us in. We saw this picture in the slide deck. I could go to register, right? And it'll actually go through the research ethics form that a person can say, yes, I consent to. Then there's this is online, certain infections are reportable, health department will be involved, we will be transmitting any information as required. Select and continue, and here's the actual registration page requiring an email or SMS validation. Now, I already have an account, so I'm going to log myself in on my phone because it will text me the code. Which changes continuously. Perfect. So now I'm in. So this is the actual website, and what we have here for the WordPress admin is just so I can actually get into the back end of the system. People would see their account settings, their order history, right? And just sort of the tests that I've ordered. So how have we automated all of this? So an individual selects order a kit. They confirm their address. This is the sexual health clinic for me. And the beginning is actually sort of a risk screener. It's a safety screener saying there's a few questions that will deem an individual ineligible, and we'll recommend you may want to be doing self-testing, but what's actually recommended for you is you go and see a clinician in person. Having symptoms suggestive of an STI is one of those indications where we would refer somebody out. So does the individual have symptoms? If I say yes, it's going to give a list of local resources, contacts, and ways to actually get access to care. So I will select no to continue along. The next was, am I a contact of somebody who's diagnosed with an STI? Recommendation is you go and be seen for epidemiologic and empiric treatments and follow-up. I'm going to say none of the above. Next is, do I need post-exposure prophylaxis or emergency contraception based on a recent sexual contact? So I'll say no. Do I have a bleeding disorder? So the HIV self-test is not approved for use by Health Canada if you have a bleeding disorder. In fact, WHO, CDC, the FDA, none of them approve the use of these devices if you have bleeding disorders. So that's a no. Am I taking part in an HIV experimental vaccine study? I say no. And am I taking pre-exposure prophylaxis? Now, this question isn't inherently, as Alex said, it was originally an exclusion criterion that has been changed. If I say yes, the next question will be, are you doing routine follow-up every 12 weeks, every 3 months with your PrEP prescriber? If the individual says yes, then it's going to say, if you think you need HIV testing more frequently than every 3 months while you're taking PrEP, go and see whoever prescribes this to you. But what we get from this, and this arises from my clinical experiences, there are not a large, but there's enough people who I will see clinically. They'll come in and they'll say, yes, I'm on PrEP. And I'll say, well, why are you here for blood testing? And they'll say, well, the person prescribes it to me for a year at a time and I don't do any follow-up. This is not the clinical guidelines. And so what we have here is, if they say, yes, I am taking it, but I'm not doing the quarterly blood work as is recommended, right? They have the ability to actually go through this. We also then reach out to the person and we provide additional information through the website. Here are the guidelines. Here's what you should be doing. You can take this to your provider. And it also serves as an opportunity for us to reach out and give some education to these providers. This is not punitive whatsoever. This is, in fact, more or less early adopters, right? Although PrEP's been around for quite a while now, but these are the early adopters in primary care who are saying, no, I am willing to do this prescription. They just need a bit of guidance about what the actual guidelines are. So our reach out is, this is great, this is excellent, we're so happy you're doing this. We just want to give you a bit of information to make sure you do it more in line with the recommendations for clinical practice. So I'll say no. Then it gets into ethnicity. I'm going to take the same thing. So this is a white man. Sex, gender, who was cis. Sexual orientation, the person can select. Ever sexually active. If I say no, it's going to take me to, do I use any drug equipment, share drug equipment? Yes, I am sexually active. I'm redoing the case, that case 2 of the 42-year-old man. He reported that his sexual partners were cis men. We had none of the above for the risk factors. He has a penis. he reported oral sex given received, anal sex top and bottom. Condom use for penetrative sex. This was not a question that we saw in the Sheets document, but we'll say he says sometimes. And any sex work, so exchanging sex or drugs for money or exchanging money or drugs for sex. I'm going to say no, that was our answer. Ever tested before? Yes. So we're going to say us tested. Any ever diagnosed? Yes. It said he was diagnosed with chlamydia and syphilis. Next. So it's thinking. We just jump to the next question. We have some. Like my internet. Ever diagnosed? I'm just going to select no there. Have you ever been diagnosed with new people since? Have you had sex with new people? Yes. Said new partners. And have you ever shared drug equipment? Right. This includes, and that was a no. So what comes out of this now? Please ignore this red box part because that is just because we're in my account and this is some debugging and development pieces. So it says, based on the information you provided, right, we recommend to you an HIV self-test, and the person has the ability to continue to shipping. We also have, for complete and comprehensive testing, right, we also recommend you do an oral swab, a rectal swab, a urine test, all for gonorrhea, chlamydia, HIV, hepatitis C, and syphilis testing. Please, right, print this or take a screenshot, show it to your family physician, nurse practitioner. You can go to a walk-in, or we have a link here to the sexual health clinic finder that exists in Ontario. So we have the full automation that exists. As I said, our goal with expansion is to move toward putting all of these bullets above the continue to shipping as we move through sort of the authorization processes and making sure we can do this according to all of the rules and regulations that are needed to be followed. But for now, seeing as we built it, we want to make sure people actually have a list. We know that individuals go to walk-in clinics in primary care and they do have to negotiate and sort of navigate on how to get the testing they feel they want. So here, at least we have the ability for people to say, I went through the GetaKit system, right? And these are the tests that are actually recommended as we move into actually bringing all of these tests above into the continue shipping. So once the person hits continue shipping, they have the ability to ship it to their house, right? And then that actual box is going to show up, and then the unmarked parts here will have a 4x6 shipping label. They can select a pickup location through the sexual health clinic, through a pharmacy we have located downtown Ottawa, the AIDS Committee of Ottawa and Max Ottawa, and they could actually go and pick up kits there. They could say that I'm on site, and the AIDS Committee of Ottawa and Max Ottawa actually has on-site registration where people can use their laptops and computers to actually go through the registration if they have difficulty with computer, phone, or internet access. And then I already have a kit if somebody has one that they obtained somehow that they want to come back and register. I already have a kit. It also works for some of the low barrier testing we're using in the consumption and treatment sites, so the safe injection sites, where people are actually able to fill out this entire process by paper, right, which is what we have here. And then a staff member would actually input, say, already have the kit, and it registers it in to have low barrier testing options. So I'll say ship to my address. Review order, right? It confirms I'm getting an HIV self-test. I place the order. And what I have now is this little red exclamation mark saying, right, you're going to get all of this shipped to you imminently once we have it. So I'm going to stop sharing for just a second as I get in to show the back end of this very quickly so that we can then get right into the questions, just to show people what it is. But I want to get in, there we go, without actually showing people. There we go, share. All right, so I'm now sharing the backend. Yes, perfect. So this is the exact file that we just saw. This is me, but through the backend, different example orders. Here's the one we just did at 1246 listed as pending. So when I go into the order, right, you can see the demographic information. The questionnaire that we just completed is all listed here in all results and practices. The tests that are ordered, the HIV self-test, plus all of the excluded tests, just due to saying these are also what were recommended, but not actually offered. Shipping, individual had selected shipping, so this will basically build and buy a Canada Post shipping label that will create it, and then we have the ability to print it right from there. the results that the individual can report, and actually being right here. So once they report a result in, it will show up. Emails, the system has the ability to actually send emails either manually or automated. So what happens is within an hour of that actually being placed, individual will receive an email saying, thanks for ordering, we're going to review it. We'll be sending you your shipping label once it's actually available. And then notes as well, if we want to actually add in anything. And a note, if I were to just do test note, will be saved in an uneditable under the time, right? The reason, the user, and the test note. And this will switch from now to the actual date and time once we have it. Once I switch this to shipped, there we go. I just got the text message saying that my order has been received, approved, and shipped. And it would, if I had purchased a shipping label, it would have sent the Canada Post tracking number as well. So the final piece with this, I'm already logged in, so I can jump quickly, is this outstanding. I can't reorder now until I actually report a result. And as I report the result, if I select invalid, right, it gives us more information, a how-to video. Negative, it's going to talk about when to retest, information on PEP and PrEP. And if I report a positive result, it gives more information, resources, how long it's going to take us to reach out. Plus, if somebody wants to, it has an information sheet, right, for the patients. For clinicians, if somebody goes to a clinic to say, here's what happened, here's specifically what's going on, in case the individual has difficulty relaying that. And there's a requisition without the submitter that has, right, the types of testing we want, that this was a self-test that was positive. It has us linked in with the PHO program study number, right, and we'd have access to this, and I am copied as well on this. This has to be taken, though, to an actual clinic as the submitter information is missing. So I'm going to stop sharing that, and I'm going to go back to the actual slide deck, which I think is here. There we go. And so just for the last couple slides, we have, I promised the websites, which we did, and then phase 3, I said we skipped through it. Phase 3 is actually we'll be launching COVID self-tests. We will be in Ottawa having the Lucira self-test. This is a molecular test, not antigen, the test that can be done at home. These are Ministry of Health pilots that are being run 3 across the province of Ontario, and GetaKit is one to see basically, can we use this? Who's going to order? What are the outcomes? What are the linkages to care? What are follow-up for PCR tests? And just like we are doing for STI and HIV, it's that online linkage to care and support. As Alex said, right, being able to do self-testing, but not testing alone, but being able to do so through sort of a modernized approach and the interventions that we have available to us. And so that sort of brings us to an end of the presentation. I can see there's some questions in the Q&A, so I think I'll turn it to Fiona.
Yeah, thank you, Patrick and Alexandra. That was great. As somebody whose pre-pandemic portfolio is STIs and BBIs, it's really nice to be able to talk about something not COVID, but also something that I think is a highly relevant initiative given our pandemic context. So this was great. Thank you so much. So we'll move on to the Q&A pod, and I'll just, and so, and please continue to, for our attendees, continue to enter your questions into the pod if you haven't already done so. So the first question is, what strategies did you employ to reduce invalid results? What were the learnings?
That has been a year-long struggle, and there's a bunch of enlightening things that have come out of it. One is invalid tests are specific to a test failure, in that the test device, the actual manufactured piece of material, didn't work. The first thing we learned is that in what people were interpreting as invalids were not always invalids. It was confusion about how to interpret the results. So sort of some low-hanging fruit that we got, how to first approach this is, right, how do you actually interpret the results, giving more information, more support in relation to, right, what is the actual results that are interpretable. Second was, what are some quick errors that people are making? And that came into people not necessarily giving enough blood in doing the test. And so we created sort of some resources and linkages for people to actually get more information on how to actually get an adequate supply of blood. The third came to when do you provide this information? This is key because, and this really came out of my own online shopping experience. Between when I hit submit on an order and when it shows up to my door, I am a very captive audience on messages that come to me on the new toy I just purchased. And so we basically tried to implement that for this and noticed a dramatic decrease. People were actually paying attention. You order your self-test, it's going to show up within 1 to 2 days. In that time period, that is when we're able to actually give information. And people may see the email or the text message and ignore it, but they may then be bored within the next 24 hours and say, what was in that message? And there's a quick 90-second video and steps and instructions. So those were the 3 main steps that really brought us down from that 20% invalid rate that is not like exclusive to us, but is being seen more broadly, and really brought us down to more around what we would expect, around a 7 to 8% invalid rate for this device.
Thanks. Another attendee asks, and they're asking about, I guess they have clients in North Bay, Parry Sound district, and they ask, just to clarify, if a client does not see their region included on the GetaKit website, do they select Ottawa, even if they are not in the surrounding area?
Yes, they can. As part of that, it's also if people in those areas are interested, they can reach out to me or Alex, and then we can say, right, is there a way for us to actually build a site and expand into that area? So there's a local, really what we want is to have it as local as we possibly can. But in the interim, Ottawa can be used.
Another attendee asks, as you move to incorporate additional STI tests, what collection methods will you use for chlamydia, gonorrhea, syphilis, HCV, and HIV serology specimens? Will Canada Post permit sending these specimens via mail?
So they don't need to. What we will be doing is sending the actual test to the individual. That individual will drop off at a local laboratory. So there would be nothing returned of a biologic specimen through Canada Post.
Another attendee asks, or says, really interesting presentation, amazing work being done, thank you. Can you speak to some of the steps needed to add the STI test as a mail-in option and what regulatory barriers would need to be overcome?
So I'm not a huge expert in the regulatory component. I do a lot more of the clinical work, working with different partners to do that. It really comes to just saying, right, does this fall within the scope of what's approved in Ontario, and making sure that we comply with the regulations. What those are, again, I'm not super familiar, but it's like getting us toward that. It may, for the person that's asking that, if you just message me or Alex, we may be able to link you with the people to help us understand that better and give you more information.
And another sort of question, comment for discussion. Again, this is an amazing system that you've created. Have you considered making the instructions separate from the box itself? I wonder if clients have concerns with discarding a box with information about the testing rather than a small piece of paper that can be hidden away more easily.
So yes, that's exactly what we do. I don't have it with me here. So the actual info sheet is like this sheet itself. The box itself is, we have redesigned and we'll be moving to a new one that will go from the kind of fold out into what looks more like a hamburger box. And the hamburger box, you actually take out the piece of paper, you take out the actual testing, like that workstation we built, and you're able to do that separately. So yes, it wasn't, it actually, we were just doing it to streamline it and make it a simpler process, but that idea of actually separating it so the box is easier and more discreet to discard is a great point that we didn't think of, but happens to align with what we're doing. It's nice when that works out.
Another attendee asks, when you do add the STI testing, who would be the ordering provider on the requisitions?
So the STI testing will occur with local providers exclusively. The goal is we would roll this out in Hamilton, where we have an infectious disease physician, Kevin Woodward, and in Ottawa would be me. So these would be local and restricted to those areas. It would not be province-wide. It's the same for the STI. You need to make sure that you can give treatments. And so this would be local to specific areas where we have linked providers.
Another attendee asks, do you have any idea how quickly you will be able to start sending out STBBI test kits? They also ask, would you ever consider offering requisitions to be printed instead of sending kits?
Yes. That's yes, that's definitely the case, because you could get like a myriad of options, right? Like if you don't need self swabs, if you don't need like, because you can go to a lab and they can do a syphilis and an HIV blood test, they can do a urine gonorrhea chlamydia test. So in those cases, what we actually have is just an envelope that goes to the person with the requisitions. But the ability to actually move forward with the technology and say, select your local laboratory, they select it, and then we could actually like fax it over to that laboratory. So it's sitting waiting, right? This becomes a paperless system that's actually much more secure and much more robust. So yes, that is in our thinking, because you would get anything from, you get all the self swabs plus a self-test, plus requisitions for blood work and urine testing. Two, you really just need to go and provide samples that like labs are authorized and legally able to collect on site.
Great. And so I think we'll take two more questions maybe. Let's see if we have time. Can you please clarify the criteria for the system offering Hep C testing?
So what we have is strong recommendations, the once lifetime recommendation for anyone who is baby boomer, right, within that sort of age bracket. For any men who have sex with men who is HIV positive, there's a recommendation for annual screening. And then men who have sex with men who have risk factors for hepatitis C, there is a consider annual. And anyone who is reporting bloodborne exposure, right, sharing of injection drug equipment, would also have the recommendation for a more frequent testing. So in those categories, it would move it in. I had put consider in the slide deck because this was men who have sex with men, but he was not HIV positive, and there wasn't any information on when the last testing was done.
So I think we've run out of time for questions, but there are still some questions in there, I think, for individuals or agencies interested. So I'm sure our presenters can follow up with them. As we wrap up today's PHO session, I would like to thank Patrick and Alexandra for presenting. I would also like to thank everyone who was able to join us today for our webinar. It's great to see such a strong virtual participation during such a challenging time for our healthcare professionals. Please note that due to system maintenance, you can expect to receive the brief and anonymous survey for today's session on Monday, September 13th. And we ask that you please try to complete that survey in order to help us to improve our programming. And lastly, to access past presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. All right, thank you very much, everybody. Have a great day.